Hi, I'm Dr. Donna Groulet, and this session will review the cost, access, and quality issues surrounding healthcare in the United States. The cost of healthcare in the U.S. means different things to different groups. For example, consumers of healthcare, such as the public, view cost as the price. How much do I have to spend for the physician, hospital stay, prescriptions, insurance premiums, and other related costs to obtaining health care? At the national level, the cost of health care refers to how much our economy is spent on health care, which is listed as a percentage of gross domestic product, or GDP. A third cost definition refers to how much providers have to spend to deliver health care, such as supplies, salaries, equipment, and even the space in which care is delivered. So when you hear the phrase, the cost of healthcare, always understand in which context this is used. Then you will have an appropriate definition based on that context. Trends in healthcare expenditures can be evaluated in three different contexts. The first is to compare medical inflation to general inflation in the economy. This is measured by annual changes in the Consumer Price Index, or CPI. Except for a brief period of time during the late 1970s and early 1980s, this rate remained consistently above the change in CPI. A second trend is to compare changes in the national healthcare expenditures to GDP, or gross domestic product. Again, the national expenditure of healthcare is consistently above the gross domestic product. What this means is that healthcare consumes a larger share of the total economic output, which means more of our economic resources are spent on healthcare. Comparing the U.S. expenditures to other countries is the third trend. This chart shows an average cost spent on healthcare per capita. In red is the average cost that first world nations spend, about $3,000 per person. On the far left is the U.S., which spends on average $8,000 per person on healthcare. In other words, this means that the U.S. spends more of its economic resources than any other developed country on healthcare. And here are some reasons why healthcare in the U.S. is more expensive than other developed first world countries. I'm going to highlight several of them, not all of them. Healthcare is one of the few services which is not paid for by the consumer. It is reimbursed by third-party payers such as the government and private insurance. Consequently, the consumer doesn't really know how much his or her procedure really costs, or office visits or hospitalization. They don't know the true cost. New medical technology is expensive to develop. In addition, U.S. healthcare uses this to diagnose and treat illnesses and injuries. Compared to Canada and European countries, the U.S. invests far more of its economic resources into technology research and development. This isn't necessarily a bad thing, but it also indicates why healthcare is more expensive. Due to the rise in life expectancy, more people are living longer. According to data, 2.6 times more healthcare dollars are spent on people aged 65 years and older compared to younger people. And variations in how patients are diagnosed and treated account for higher healthcare costs. A recent study demonstrated that regional variations in Medicare spending using specialists and inpatient care, but with lower quality patient satisfaction and health outcomes for those with higher utilization. Because we do not have standardization in healthcare across geographic areas and diagnostic codes, this leads to higher healthcare expenditures. So, how does the U.S. reduce healthcare costs? Cost containment measures are divided into two categories: regulatory and competition. On the regulatory side, health planning enables policymakers to limit the number of beds and diffusion of expensive technology. In order to avoid a monopoly on the supply side, price and utilization controls are implemented as well. These include limiting Medicare reimbursement rates, rate increases for physician services, and medical peer review of utilization and quality of healthcare services. But on the competition side, cost control measures include cost sharing, which means that patients or consumers share the cost of healthcare through co-payments, which leads them to ration their own healthcare. Managed care has helped to control utilization of care and drive down costs through payer competition. Now, let's shift to how patients can access health care, which is one of the determinants of health. Access refers to a person's ability to obtain health care services when they are needed. There are 5 dimensions to access: availability, accessibility, accommodation, affordability, and acceptability. Availability of healthcare services refers to the match between the service capacity and the individual's requirements. Some examples include sufficient healthcare specialists, social services, and even primary care that are available to patients when they need them. Accessibility means the fit between the location of providers and patients. Things such as convenience, design, and payment options are covered in accessibility. This graphic shows an example of accessibility from a disabled patient's point of view. Has this ever happened to you? You call to make an appointment to see a physician, and you get an appointment for the same week. This is an example of accommodation. Can a patient schedule a timely appointment or receive care within 1 day for acute, non-urgent problems, or 1 week for preventive services and exams? If so, then the healthcare system has accommodated the patient. Can the patient afford to pay for healthcare services? Affordability includes having the financial resources for co-payments, prescriptions, and even insurance premiums. Acceptability refers to the attitudes of patients and providers towards each other. A patient's attitude of acceptability changes whether they perceive that the value is worth it in terms of the patient's perception. For example, my husband saw a neurosurgeon for several years. The time wait for a scheduled office visit was often more than 2 hours long, which normally would be considered unacceptable. However, because of the excellent care that he gave to his patients and the realization by them that he was often called into emergency surgery, all of his patients accepted this longer wait time because of the care that they received from him. These 5 dimensions seem fairly vague or ambiguous, so how do we measure access? Well, there are 3 levels of access. The individual level, access is measured by the individual level, access is utilization. At the individual level, access is measured by utilization of services and the patient's assessment of their interaction with the provider. A patient's perceived level of access is tied to patient satisfaction, which means that if the patient perceives a high level of access to services, their satisfaction with those services is high as well. At the health plan level, access includes characteristics of the plan that impact enrollment of patients, such as cost of insurance premiums, co-payments and deductibles, out-of-plan usage, and plan practices such as referral services, travel distances, and wait times. At the delivery system level, access accounts for population rather than individual measures. These include policies and programs, ratio of physicians to population, hospital beds per 1,000 population, percentage of households with insurance coverage, and median household income. Now let's focus our attention on the quality of healthcare, which is hard to both define and measure. The Institute of Medicine has defined quality as the degree to which health services by individuals and populations increase the likelihood of desired health outcomes and are consistent with current knowledge. This definition has 5 implications. Quality occurs in a continuum ranging from unacceptable to excellent. It focuses on the services provided by the healthcare system rather than the behavior of the patient. Quality can be evaluated at the individual, patient, or the population level. It relies on research data to identify services that improve health outcomes. And finally, there are a variety of factors that define health or determine health beyond simply providing services. There are several processes that have demonstrated improvement in healthcare quality when implemented. Clinical or medical practice guidelines are detailed descriptions of preferred clinical processes for specific conditions. These are scientifically based protocols that guide clinical decisions with the goal of best practice approaches for that healthcare condition. Cost efficiency refers to the benefit being greater than the cost of the service. There are 2 terms to remember: overutilization and underutilization. Overutilization or overuse occurs when the cost of the treatment outweighs the benefit. Over time, the value of this treatment is diluted due to wasted resources and unethical use of care because it deprives others of the benefits of healthcare. And then underutilization is the opposite. The benefits actually outweigh the costs, yet the treatment is not used. An example would be low birth weight babies due to a lack of prenatal care and low cancer survival rates due to the lack of early detection and treatment. Clinical pathways are management tools that facilitate interdisciplinary coordination of care. It serves as a plan of action for all disciplines caring for that patient based on the availability of those resources. An example is the team of healthcare providers that treat a spina bifida patient, including primary care, respiratory, neurology, orthopedics, physical therapy, and other healthcare specialties. And then risk management includes proactive measures to avoid adverse events, such as medical malpractice, by incorporating the above 3 processes into addition to others, such as surveilling the physical environment for hazards, and learning from adverse sentinel events by conducting root cause analysis to change practices and behaviors that would lead to a similar event. Finally, I'd like you to understand how quality is actually reported. Because if an organization doesn't measure and report healthcare quality, it then cannot improve delivery of services or health outcomes. The Centers for Medicare and Medicaid Services, or CMS, review indicators for the patients that it covers, which are the elderly and the poor. Initiatives include physician, outpatient surgery, electronic prescriptions, and reporting on specific diagnostic codes. The Agency for Healthcare Research and Quality, AHRQ, is tasked with improving both inpatient and outpatient quality of care through reporting of a set of quality indicators, or QIs, that measure the quality of process of care. For example, the Consumer Assessment of Healthcare Providers, CHAPS, researches the patient experience to determine how that relates to and influences patient care and quality. It surveys items that the consumer can truly assess, such as communication skills of providers and ease of access to services. The goal of this presentation is for you to have a basic understanding of the U.S. healthcare delivery system and how cost, access, and quality are important deliverables, not only from a patient and systems perspectives, but also from an economic perspective, given that we spend so much more of our economic resources on healthcare than other developed nations. I'm Dr. Goulet, and thanks for watching.